My name is Jenna Aiello, and this is my PowerPoint on the treatment of aphasic perseveration. What is perseveration? Perseveration can present as a repetition of a previously used phoneme, word, or phrase in response to new stimuli. It occurs commonly in people with aphasia, and it is divided into three general categories: stuck and set, which is a continuation of a behavior or thought process; continuous, which is similar to stuck and set. It is a repetition of a behavior or action for an inappropriate amount of time; or recurrent perseveration, which is what we are talking about here, which is the repetition of a previously used phoneme, word, phrase, or gesture in response to new stimuli. A number of factors can lead to perseverations, including phonological and semantic relatedness, lexical and word frequency, level of difficulty, rate of speech, etc. Perseveration occurs in roughly 50 to 93% of people with aphasia, and the type of perseveration, certain perseverative trends tend to pop up more in different aphasias, such as with Broca's aphasia, you have morphosyntactic and phonological perseveration, whereas in Wernicke's, you have phonological and semantic errors, which are predominant. And perseveration can occur in any person with aphasia. So the major theory at work here was that perseveration occurs as a result of the overactivation and slow decay of the perseverated response and the weak activation of the target response. A single subject design was utilized, and two research questions were used. Does the treatment decrease the frequency of perseverations for trained and untrained stimuli? And does the treatment increase the frequency of correct naming for trained and untrained stimuli? The participant was a 43-year-old Latino male who had suffered an aneurysm in his left posterior communicating artery 8 months prior to treatment. His diagnosis was moderate to severe receptive expressive aphasia. The treatment consisted of a single 2-hour session once a week for a 7-week period. The dependent variables consisted of number of items correctly named and number of perseverations. Interjudge reliability was 99% for accuracy of naming, 88% for perseverations. And to test the degree of generalization, a discourse sample was taken by a use of the cookie theft picture. Treatment actually began with the baseline, which was established over 3 different sessions prior to treatment. Treatment itself consisted of 2 parts: the manipulation of the interstimulus interval and analysis of semantic features. The stimuli itself was made up of 5 sets of 10 black and white picture cards. The procedure included Munoz providing an initial interstimulus interval of 20 seconds, administered between the stimuli, which was in this case the picture naming task with 1 set of 10 cards, and then immediately followed by the analysis of semantic features task using that same set of cards. Criterion for mastery was 90% correct responses without perseverative errors, and an interstimulus interval of less than 2 seconds. SD's level of perseveration decreased by half. His verbal output increased, but there was no increased ability for naming, although Munoz believes that he became more adept at other compensatory strategies, such as circumlocution, because of the learning that he experienced via the naming tasks. Munoz's conclusions include the fact that she thinks the treatment was too short, that they needed to have done more frequent and longer treatment protocol for better results, and she believes that more research is really necessary. My next study is Helm, Estabrooks, Emery, and Albert's treatment of aphasic perseveration, a new approach to aphasia therapy, which identifies perseveration as not solely a symptom of aphasia, but as a defining characteristic. They see perseveration as a stifling of the production of an appropriate target. The TAP process requirements include a relatively intact memory, and the therapy's main goal was, to make the participant aware of the perseverative error. They believe that this burgeoning awareness would lead to greater control of output, thereby reducing the number of perseverative errors. So the TAP design was an ABAB model. So they would start with TAP, do language therapy, traditional language therapy, go on to do TAP again, more language therapy, and then end with TAP. It was a within subjects design. There were 3 participants. and they were chosen according to how they scored on the BDAE. So after each treatment phase, the participants were tested for treatment effects. Participants were tested for remediation after each treatment interval as well. All participants were rated as being in the moderate to severe range in terms of their frequency of perseveration. And based on the BDAE scores, clinicians devised a series of cues that worked best for each perseverative client. So instead of utilizing a specific cueing hierarchy, a series of cues was devised specifically for the participant. Treatment consisted of a number of factors. Cueing hierarchies were developed based on individual strengths and weaknesses. 3 specific cues were used per person. 38 different stimuli were used, consisting of a number of different categories such as shapes, animals, colors, etc. And the scoring system was made up of 2 specific components: the number of perseverative errors and naming accuracy. The strategy itself, the treatment strategy itself, consisted of a person with aphasia being made aware of their perseverative errors and instructed to either not respond to stimuli or to ask the clinician for help if they could do so without perseverating. And in between tasks, the clinician enforces a 5-second interstimulus break. So the results were pretty positive. All 3 participants showed an increase in naming and a decrease in perseverative errors. The decrease of perseverative errors was 33 to 85% between the 3 participants. And the TAP therapy actually worked better than the standard language therapy. Some of the TAP protocols were less efficacious than others. The interstimulus intervals were useful in decreasing perseverative errors, although the tearing up of the pieces of paper and then putting them within the eye line of the participant was less effective in helping them not perseverate in that moment. My next article was the study by Cohen et al., and they studied whether one of 2 different treatments was more efficacious in halting perseverations in people with aphasia. Basically, their working theory was that people with aphasia would produce more perseverations during a filled interval than a silent interval. And this was all premised on the idea that perseverations are a result of a slower decay of a past response working against the weak acquisition of a new target response. A within subjects design was used. A sample of 14 people was utilized. They all had different types of aphasia and different degrees of severity. The dependent variable was the number of perseverated whole words that occurred during the 2 interstimulus periods, and t-testing was used to compare perseveration rates during both the filled and silent interstimulus conditions. The 2 separate tasks were the repetition of word string phrases, and the 2 separate intervals were filled and unfilled. The dependent variable consisted of the number of perseverated whole words that occurred during the 2 interstimulus periods. Treatment included 2 word repetition tasks as completed by all participants. One task included 60 words total, the other 90 words total. Interstimulus intervals consisted of silent and filled. For silent intervals, participants were instructed to sit quietly for 5 seconds. For the filled intervals, participants were instructed to count in tandem with the clinician. The authors noted that a silent interstimulus interval does help decrease perseverative errors in people with aphasia, and they propose that this may be due to the added time, which allows for a strengthening of the target response and the decay of the previous response. They further contend that filling those interstimulus intervals with repetitive tasks takes away time and cognitive resources that could be spent activating the appropriate targets. There appear to be 2 schools of thought surrounding the nature and treatment of perseveration, 2 competing theories about why perseverations occur and how to treat them. The first contends that perseveration is a symptom of a larger pathology and perhaps indicative of a greater degree of language breakdown and should be treated within a more comprehensive framework for targeting aphasic behaviors. The second school of thought speaks to the idea that the treatment of perseveration in and of itself can increase the overall output and foster other compensatory skills like circumlocution and positively affect neighboring symptoms such as anomia. The theory that perseveration is a product of the brain's dysfunctional language centers, overactivation of a perseverative response, and the underactivation of a target response, I think is pretty compelling. It is particularly compelling in light of the fact that of the treatments referenced, the single greatest factor contributing to the decrease in perseverations was the introduction of short, silent interstimulus intervals. Silent interstimulus intervals appear to be efficacious in treating perseveration, which is in keeping with the idea that the aphasic brain takes longer to produce appropriate non-repetitive responses. And finally, sensitizing patients to the fact that their repetitions are due in part to a slowed processing power and to remember to take minutes to breathe, relax, to not force a production, are all methods that should probably continue to be explored with an eye towards decreasing perseveration. As it is, these techniques, they're already components of most comprehensive aphasia therapy, and hopefully more studies will be conducted on the efficacy of these sorts of interventions.